Here the IPDA is originating. Here it is bit clear picture, and so again analyzing the IPDA and the this first duodenal artery. It's important whether there is a common trunk. Hi everyone, welcome back to the channel. Today we are diving into the arterial anatomy involved in the Whipple procedure, specifically focusing on what we often overlook or fail to analyze thoroughly before surgery. Friends, this is crucial for avoiding complications and ensuring the best outcome for our patients. So let's get started. So in this series, we have already uploaded 3-4 videos like a quick overview about the incision and the cauterization, and I hope you have already watched them. If not, do watch them now before joining us here. And for a better learning experience, please download our app available for Android and iOS or join the channel membership. The link for everything is given in the description of this video. The Whipple procedure or the pancreaticoduodenectomy, it's a complex operation. Understanding the arterial anatomy is vital. So let's quickly revise the anatomy. And as I said, in this video we are covering just the basic points or the important points which are usually missed during the preoperative analysis. So friends, as all of you are aware, that the celiac trunk arises from a direct branch from the aorta at the level of T12. There are three branches: common hepatic artery, splenic artery, and left gastric artery. So from the common hepatic artery arises the gastroduodenal artery, which divides into the anterior and posterior superior pancreaticoduodenal artery. From the splenic artery, we get dorsal pancreatic artery and the great pancreatic artery. And from the left gastric artery, sometime there will be a replaced or accessory left hepatic artery. And at the level of L1, there will be superior mesenteric artery SMA as a direct branch of the aorta, which give rise to the inferior pancreaticoduodenal arteries that will be anterior and posterior branches of IPDA, and sometimes there will be replaced or accessory right hepatic artery as a branch of the SMA. So friends, it is important to understand as far as the main arterial anatomy of the pancreatic head is concerned. So basically there are two arterial arcade. One is coming from the superior, that is from the GDA, that will be superior pancreaticoduodenal arcade, and one will be inferior, that will be from the SMA, that will be inferior pancreaticoduodenal arcade, and basically the anastomose, and it is a bridge between the celiac trunk and the SMA. So these are rich collaterals and the anastomose with each other, and this is a very rich vascular supply, and that will also the rationale behind the lymphadenectomy. So we have to clear the lymph node basins around these vessels, that will be the GDA and the SMA and the superior and inferior pancreaticoduodenal arcades. So I apologize in the beginning only. The recording is not so good, or it is a bit suboptimal, but this was the best we could get, and we will keep running this thing time and again so that you can understand, and whatever the point we discuss you have to revise so that you understand the things better. So in the first freeze frame here, in this fissure between the segment 2, 3 and 4, you can see a arterial structure. So first we are analyzing the arterial phase of the pancreatic protocol. So here is lateral segmental artery between the fissure, and it supplies the segment 2 and 3. Here, if you trace, you will get the replaced or accessory left hepatic artery, which will arise as a direct branch from the left gastric artery. That's not the case in this patient. The next thing that you have to analyze is this dorsal pancreatic artery. So it is originating from the SMA and moving towards the head area or the head of pancreas, and this will be encountered during the surgery while doing the uncinate first approach. So again you have to remember this anatomy is variable, and dorsal pancreatic artery here is arising from the SMA as a direct branch. The next vessel as highlighted here will be the gastroduodenal artery, And so, as I said, it is a direct branch from the common hepatic artery. After that, it becomes the hepatic artery proper. So it divides into anterior and posterior pancreaticoduodenal artery. And as highlighted, you have to remember the location of the artery, and the cystic lesion in the pancreatic head is also coming into view. So in this part, we are highlighting the posterior superior pancreaticoduodenal artery, PSPDA. So why we have highlighted here that it is the branch of the GDA, the gastroduodenal artery. As I said, the posterior branch, anterior will be anterior posterior, anterior superior pancreaticoduodenal artery, and sometimes this PSPDA will arise directly from the common hepatic artery. So, in that case, you have to remember that after ligating the GDA, there will be another arterial structure originating from the pancreas going toward the originating from the hepatic artery and going towards the pancreas. So you have to ligate another arterial structure that will be PSPDA, which is not the case in this patient, but you have to remember this variation. The next arterial structure that we will analyze will be the inferior pancreaticoduodenal artery, and as I said, it is a direct branch from the SMA. And in this case, it was arising as a common trunk, that is the first jejunal artery, and the IPDA was arising as a common trunk from the this. SMA. So, just below that is the second jejunal artery. Again, we will repeat the sequence and you can relate it better. So, that means while doing the artery, this uncinate and approaching the SMA, you will encounter this IPDA and the first jejunal as a common trunk, and just below there will be the second jejunal artery. And it is important to analyze this anatomy in the preoperative setting, because intraoperatively it is difficult to ascertain that we are dealing with which part of the structure we are dealing with. And as I said, this part is not commonly analyzed in the image, and this is what I wanted to highlight. So briefly, let's discuss the venous anatomy also. And so friends, here in this part you can see the GCT, the gastrocolic trunk. Remember, you will ligate. This will be the structure that you will ligate while after opening the lesser sac, and this will make a difference between the outcome. So this will be a complete guide, so stay tuned. And for a better learning experience, do download our app or join the channel membership for premium access or exclusive access to our content. And so, thank you very much, friends. I hope we were able to add some new insight to your knowledge. Do like the content, share this content with your friends, and subscribe to our channel and hit the bell icon for all the future updates. Thank you very much. Happy learning.